This video is a schematic introduction to the anatomy of the inguinal canal and is really a form of caricature in the hopes that it'll simplify it for further understanding. The inguinal canal is a site of relevance clinically in both males and females, but it plays a much greater role in clinical practice in males. Of course, in the male, it's responsible for transmitting the spermatic cord and supplying the contents of the scrotum so that they can communicate with the intra-abdominal contents. And in females, the passage of the round ligament of the uterus going into the labia majora are noted. But the size of the canal in the male is larger than that in the female, which is why it's a site of clinical problems more in males than in females. Whenever there's an increase in intra-abdominal pressure, such as during coughing or laughing or straining at stool, there is a tendency for any mobile organs to want to move out through any potential weakness in the abdominal wall. Now, the inguinal canal is located at a site of such weaknesses, and the function of the inguinal canal is to permit structures such as the spermatic cord to leave the abdominal cavity and to go down to supply the structures that it needs to supply, such as the testes, while at the same time preventing mobile organs such as omentum or intestines from doing the same thing. It is also important that structures that are intended to leave the abdominal cavity do so without being compromised in any way. Now imagine the right side inguinal canal viewed from the front as a box. It's got anterior and posterior walls, and it's got a roof and a floor. The two sides are open, and that's why you can see the big black arrow going through it. The arrow indicates that structures can run through it from lateral to medial, and in the male this will be the spermatic cord, and in the female this will be the round ligament of the uterus. Now let's replace the roof and the anterior wall. I've made the roof slightly transparent, and so too the anterior wall, and through the top of the transparent roof you can see the weakness in the posterior wall, which is the deep inguinal ring. However, now in the anterior wall you can see that there's a defect represented by a similar circle over here, and this is known as the superficial inguinal ring. So the superficial inguinal ring is found medially in the anterior wall, while the deep inguinal ring is found laterally in the posterior wall. Now in this view the roof has been removed, and we can clearly see the posterior wall of the inguinal canal. There's the deep inguinal ring, and here's the anterior wall with the superficial inguinal ring. In the male, the spermatic cord will enter through the posterior wall, through the defect of the deep inguinal ring. It'll run along inside the inguinal canal and then come out through the superficial inguinal ring, the defect in the anterior wall of the canal. Here the spermatic cord will then go through and go down into the scrotum to supply the testes. In the female, the round ligament of the uterus will follow a similar course. Now, what forms the anterior wall of the inguinal canal? Remember that in this structure that skin and superficial fascia have been removed, so this slide is concerned with the muscles that make up the anterior abdominal wall. Structures most medially involved are the external abdominal oblique muscle, and that's found throughout the whole length of the anterior wall of the inguinal canal. A little more laterally, we find the internal abdominal oblique muscle immediately posterior to the external oblique, and it reinforces the lateral third to a half of the inguinal canal. And then a little further laterally, we find the transversus abdominis, which contributes to the integrity of the anterior abdominal wall laterally, but has little to do with the formation of the inguinal canal itself. Now, in this diagram, we see how the roof of the inguinal canal is formed. Situated here, we can see the transversus abdominis. That's the deepest of these three anterior abdominal wall muscles. And then a little bit more superficial to that is the internal abdominal oblique. Now, these muscle fibers combine to form a tendon known as the conjoint tendon. And this tendon arches over from lateral to medial, forming the roof of the inguinal canal. Whereas there's a defect in the posterior abdominal wall, or posterior inguinal wall rather, and a defect in the anterior wall so that the spermatic cord can get through, the transversus abdominis and the internal oblique do not have a defect. Instead, they form this tendon that arches over the spermatic cord so that the cord does not have to run through these two muscle layers. This conjoint tendon runs from lateral to medial and from anterior to posterior, so that while it arises laterally and anteriorly, the conjoint tendon will come down and run against the posterior wall of the inguinal canal medially. So just to repeat that, from lateral to medial and anterior to posterior. So looking at some more detail of the posterior wall, you can see here the deep inguinal ring, which we know is an area of weakness, and the conjoint tendon, which is arched over, then comes round and attaches just anterior to the posterior wall, reinforcing it medially. We'll see why this is important in a moment. The structure of the posterior wall is made up thus of transversalis fascia, as I'm indicating here, throughout its whole length, and medially it is formed by transversalis fascia with the conjoint tendon situated anteriorly. The floor of the inguinal canal is formed by an incurving of the inguinal ligament. Now you will recall that the inguinal ligament is formed by the aponeurosis of the external oblique abdominis muscle. So the aponeurosis runs down here on the front of the abdominal wall, and then as that aponeurosis comes down, it forms the inguinal ligament, which itself curves under to go and attach onto the anterior superior iliac spine and the pubic tubercle, and the incurving under here forms a gutter along which the spermatic cord will run as it traverses the inguinal canal. So to summarize this section, the roof of the inguinal canal is formed by the conjoint tendon and the meeting of the anterior and posterior walls of the canal. Remember, the conjoint tendon is formed from the transversus abdominis muscle and the internal oblique abdominis muscle. And then the anterior wall is formed throughout its length by the external oblique muscle and more laterally by the internal oblique muscle. Remember that the anterior wall is weak medially because of the presence of the superficial inguinal ring. To reorientate ourselves, this is a view of the inguinal canal from the front. Over here is the medial aspect. Over here is the lateral aspect. In this diagram, the roof, which run over the top here, the roof of the canal has been removed and the anterior wall has been made transparent. The schematic cord can be seen running through the deep inguinal ring and then running in an S-shaped path through the inguinal canal, lying on the floor and exiting through the anterior abdominal wall at the superficial inguinal ring before going down through into the scrotum. Now remember that the purpose of the inguinal canal is to allow structures that run through the schematic cord to leave the abdominal cavity and enter the scrotum, at the same time preventing other mobile structures within the abdominal cavity from doing the same. As part of everyday life, there are periods when we're going to have an increase in intra-abdominal pressure, particularly when we cough, or if we laugh, or if we strain while defecating or urinating. And that pressure will cause the mobile organs in the abdomen to push up and try and exit through the defect in the deep inguinal ring. However, the pressure on the posterior wall of the inguinal canal is not limited to over where the deep inguinal ring is, but is applied to the whole length of the posterior inguinal canal, the wall of the canal. These arrows then represent pressure on the more medial side of the wall, and this one pressure on the lateral side of the wall. Now let's spend a little bit of time looking at what happens when pressure is increased here laterally over where the deep inguinal ring is. We can see that if the pressure is just acted unopposed, then there would be a tendency to force structures out through the deep inguinal ring and push up against the anterior inguinal canal wall over here. There would then be a tendency to try and force structures through the anterior wall in this part over here. However, we know that the anterior wall is reinforced laterally by the internal oblique muscle, so that any structure that might want to come through the weakness in the area of the deep inguinal ring, when it's pushed through the posterior wall, will come up against a reinforced anterior wall and will not push out through the structures of the anterior wall because it's nice and firm. So where there is a weakness in the posterior wall, we have reinforcement in the anterior wall as a compensation. Now on the medial side, the same principles apply, but the arrangement is a little different. When there is an increase in abdominal pressure, as there is on the lateral side, there will also be increased pressure on the medial side. You will remember that the posterior wall is made up in its entire length by the transversalis fascia, and this is a very weak structure. So anything that pushes up against the posterior wall in this medial region here actually meets very little resistance over here and would push quite easily up against the weakness where the superficial inguinal ring is in the external abdominal oblique muscle of the anterior wall. Thus, there has to be some form of reinforcement of this posterior wall so that herniation or pushing through of structures in an abnormal manner does not occur. This is where the conjoint tendon comes into play. So you will remember over here on the lateral side of the inguinal canal, there's the internal oblique muscle and also a little bit more laterally the transversus abdominis muscle, and these two muscles join together to form the conjoint tendon, which arches over the schematic cord and runs down and attaches posteriorly in the inguinal canal. It attaches onto the pubis, and in doing so it reinforces the weak posterior wall. Thus, where there is a weakness in the anterior wall medially over here, structures are prevented from herniating through by a reinforcement of the posterior wall by the conjoint tendon. So let's go over that again. The posterior wall is weak throughout its length, but particularly weak over the site of the deep inguinal ring. that allows the spermatic cord to come through. It's therefore quite easy for structures to come through the deep inguinal ring, but this is resisted by reinforcement of the anterior wall by the internal oblique muscle. On the medial side, the transversalis fascia forming the posterior wall is reinforced medially by the conjoint tendon, and this prevents structures coming through trying to exit the anterior wall weakness through the superficial inguinal ring. When we cough or laugh, then our anterior abdominal wall muscles tense up, and this has the effect of compressing the inguinal canal, increasing the opposition of the anterior and posterior walls, so that the reinforcement on the lateral side presses right up against the posterior wall, and the reinforcement on the medial side presses up against the anterior wall. So the joined reinforcements medially and laterally prevent any herniation of mobile abdominal structures. It's true that the spermatic cord exits and runs through in this particular manner, and that it will be compressed during the times of raised intra-abdominal pressure. However, those periods are short-lasting, and no harm comes to the organs that are supplied by the structures in the spermatic cord as a consequence of that temporarily increased pressure. However, there are times when things go wrong, and we'll have a brief look at that in the next few slides. As an application of what we've just learned, let's look now at the condition of direct inguinal hernia, which occurs commonly in adults. We know that the posterior wall of the canal is a weak structure, but it is reinforced medially. However, if somebody has chronically raised intra-abdominal pressure, such as from a chronic cough or being chronically constipated, or having to strain at passing urine because of prostatism, this repeated stretching as a consequence of the raised intra-abdominal pressure can cause stretching of the medial reinforcement, that is of the conjoint tendon, at the medial end of the inguinal canal. The abdominal contents thus push forward on the stretched or weakened conjoint tendon and meet little resistance from the anterior abdominal wall or the anterior inguinal canal wall because of the presence of the superficial inguinal ring. And this is seen clinically as a bulge in the region of the groin, and if you ask a patient to cough, you will see it pushing forward and distending through the anterior abdominal wall. Looking at it in the same scenario in this picture, here the intra-abdominal pressure would press up against the weakened posterior wall. This whole section here, the transversalis fascia plus the conjoint tendon, would stretch, and the contents would then push up against the weakness here in the anterior abdominal wall, which is a superficial inguinal ring, and we would therefore see the contents pushing forward onto the anterior abdominal wall over here. It is perhaps important to point out that in all these hernial conditions that the walls of the inguinal canal are never actually cut or damaged. They are stretched. Even so, when the spermatic cord comes through the inguinal canal, the transversalis fascia contributes to a layer around the spermatic cord, and indeed each layer that the spermatic cord traverses will be covered by a layer derived from the anterior abdominal wall structures. It's rather like putting your finger into a glove and stretching it down through the finger hole in the glove. There isn't actually a hole in the glove when you look at it from the inside. It's really just a stretching of the coverings that is noted. As an exercise, it's worth going through the list of coverings of direct inguinal hernias that have been listed here. Look at the diagrams that we've been talking about in the presentation and see if you can work out why these different layers are present in direct hernias. If you wish to pause the presentation at this point to take down the list, please do. Otherwise, we'll continue now to the next slide. Indirect hernias are a slightly different topic and do not necessarily arise as a consequence of weakness in the abdominal wall structures. Perhaps the commonest kind of indirect hernia is that of congenital inguinal hernia, in which there's a persistence of the peritoneal sac that enables bowel to move down easily through the deep inguinal ring, along the inguinal canal, and down out through the superficial inguinal ring and into the scrotum. In repairing such a hernia, the surgeon pushes back the contents that have herniated and then merely ties off the extra bit of peritoneum inside the abdominal cavity to prevent the hernia from reoccurring. And it occurs not because of a weakness in the abdominal wall, but because of the persistence of the peritoneal sac. And nonetheless, it's worth having a look at this list here of structures that contribute to an indirect inguinal hernia, and you can work your way through these by looking at the diagrams and trying to anticipate what structures would contribute to the layering of indirect hernias. This slide and the next one are summaries of what we've spoken about here in inguinal hernias and relating it to the anatomy of the inguinal canal.